Let's talk for a few minutes about the different options for breast reconstruction after mastectomy. Now, typically, these options are broken down into areas of putting a tissue expander in first, followed by implants. Those implants are typically either saline or silicone. Another option is an option of autologous tissue, meaning your own tissue. And the donor sites for your own tissue can be the abdominal wall. Patients say to me, well, gee, Dr. Ernst, sounds like I might get a free belly tuck out of that if can we take a whole bunch of this fat down here and move it up here? So all kidding aside, that is one of the options of moving from the abdominal wall down around the belly button area, skin, the fat layer underneath, and including muscle in certain kinds of the flaps. And I'll get into some of those details in just a second. There are other donor sites for autologous tissue. Believe it or not, your butt, the gluteal region. We can actually move tissue as long as we've got an artery and vein going into it of skin and subcutaneous fat from down in the gluteal area up to here, and I'll describe in a couple of minutes. These free flaps are called, meaning that they need microvascular techniques in order to reestablish the blood supply up here. And that can be done high inside of the buttock or low on the buttock. Another option is to swing tissue from the back, called the Latissimus Dorsi flap, bring it around, tunnel it underneath, and usually that's associated with a small implant as well. There are several important points here, several caveats. Number one, you absolutely need to be working with a team of breast and plastic surgeons who are really experienced in doing these techniques. This is critically true when it comes to moving tissue and then reestablishing the blood supply up here with microvascular techniques. That absolutely takes a team approach. We get into issues like the preoperative assessment and patient selection and making sure that you are not a cigarette smoker, or if you are, being off your cigarettes at a minimum of 3 weeks, more like 6 to 8 weeks or even longer. Remember, I've shared with you in other videos, this kind of tissue reconstruction can be done immediately, but often it's done on a delayed basis, particularly after somebody needs radiation therapy following a mastectomy and chemotherapy. The different kinds of flaps have big fancy names associated with them. One is called the Tram Flap, T-R-A-M, standing for big fancy words here. Transverse, Rectus, Abdominus, Myocutaneous flap. The Tram Flap, been around for a long time. The flap can be rotated up, maintaining its own blood supply down below, or it can be done again as a free flap, meaning you find the donor vessels down below, the ones that are with the tissue, move those up, and then usually off of the internal mammary vessels between the ribs, we can then have the microvascular anastomoses done there. Another is the Diep Flap, D-I-E-P flap, which is the deep inferior epigastric artery perforators. And this involves moving certain sections of the skin and subcutaneous fat, but not muscle. If you are moving muscle from down below, then you have to reconstruct where that muscle has been donated from with mesh, and this can be, frankly, a very big operation and somewhat debilitating to people. Another is an SIEA flap, which is a superficial inferior epigastric artery flap. All of these flaps have advantages and disadvantages. And like everything that we do in the world of breast cancer, there's no absolute one correct answer. Each one of these flaps that I've described to you, if it's a free flap or a rotation flap, each has advantages and disadvantages. The biggest thing we worry about is losing the blood supply. If we lose it completely, like the artery clots, we could lose the entire flap. which would be obviously somewhat catastrophic if that happens. So again, it's the experience of the team that's really important. It's patient selection based upon your body size and type, how much tissue needs to be moved, what the circumstances are about your cancer. Way too many factors that I can cover here in a few-minute video with you. So again, as I always say, be involved with a multidisciplinary team, be involved with a group of plastic surgeons who are really experienced at this and have a major track record. If you do so, odds are really high that whatever flap is chosen is going to be successful for you. Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.